Hello friends, in this video we are going to talk about soap. So what is soap? Soap is a pathological process that results from inadequate tissue perfusion leading to cellular dysfunction and organ failure. So what are the characteristic features? Due to the failure of the circulatory system, either due to decreased cardiac output or reduced effective circulating blood volume, leads to the systemic hypotension, which leads to the life-threatening inadequate impaired tissue perfusion, meaning that tissue does not get enough oxygen, or you can say blood. Okay, it leads to the reversible tissue injury, and then it leads to the irreversible tissue injury, then organ failure and death. Okay, so this is the um, features of the shock. Major types of shock are hypovolemic shock, cardiogenic shock, septic shock, neurogenic shock, and anaphylactic shock. Okay, we will discuss all these in the detail. So let's first discuss about the uh, hypovolemic shock. Okay, hypovolemic shock results from low cardiac output due to the loss of blood, for example, massive hemorrhage. Then either due to the loss of plasma, for example, severe burns, loss of fluid, vomiting, diarrhea, or severe gastroenteritis, for example, in cholera infection. Okay, so loss of fluid, loss of plasma, and loss of blood. Okay, now what happens? So if due to the blood loss or plasma loss or fluid loss, what happens? It uh, there is inadequate blood or plasma volume in the body, so it leads to the hypovolemia. So it leads to the uh, less cardiac output, leads to the hypotension, and less inadequate perfusion of tissue, meaning less perfusion of tissue. So then the complications we will discuss. So this is the mechanism of hypovolemic shock. Okay, so the second one is the cardiogenic shock. Okay, so it is due to the direct myocardial damage or a mechanical abnormality of the heart. Low cardiac output leads to the low cardiac output, leads to the uh, reduced cardiac output and blood pressure. Okay, principal mechanisms of myocardial damage due to the myocardial infarction, myocarditis, ventricular rupture. These all are the causes. And in mechanical damage, valvular failure, stenosis, hypertrophic cardiomyopathy, ventricular septal defect. Okay, and rhythmic ventricular arrhythmias. These all leads to the uh, impairment in the cardiac function. So if the cardiac function is impaired, meaning that decreased cardiac output leads to the decreased tissue perfusion. Okay, and the left-sided heart failure leads to the pulmonary edema as well. Okay, so this is the basic mechanism and causes of the cardiogenic shock. Okay, now the third one is the uh, septic shock. Septic shock is defined as shock due to severe sepsis with hypotension, which cannot be corrected by infusing fluids. Okay, it can be caused by gram-positive as well as gram-negative organisms. Okay, such as Staph aureus, Enterococci, Streptococcus pneumoniae, and gram-negative bacteria are also usually resistant to usual antibiotics. Septic shock is triggered by these organisms. Basically, what is septic shock? Septic shock is a tissue hypoperfusion due to decrease in the peripheral vascular resistance as a result of systemic vasodilation. Okay, and pooling of blood in the periphery. You can refer to also say edema as well. Okay, so now let's talk about the mechanism of it. Microbial products uh, will bind to the certain receptors and activate the inflammatory response such as the activation of neutrophils and macrophages, activation of complement cascade, and procoagulatory state also. Okay, activation of neutrophils and macrophages leads to the release of pro-inflammatory cytokines such as TNF, IL-1, HMGB1, and many others. Okay, which also leads to the endothelial cell injury. Activation of complement cascade also. Okay, in which C3A, C5A, anaphylatoxin, then C5A also plays the role of chemotactic fragments. Okay, and C3B is the opsonin fragment. Okay, and these all complement products contribute to the pro-inflammatory state. Okay, now the third one is the activation of coagulatory state by activation of factor 8 and also by the endothelial injury as well. Okay, so this is the primary effect. There is also activation of counter regulatory immunosuppressive mechanisms as well. Okay, immune leads to the secondary inflammatory mediators, also leads to the immune suppression such as soluble TNF, IL-1 receptor antagonist, and interleukin 10. Okay, so now what happens? Endothelial cell injury or activation leads to the release of interleukin 6, interleukin 8, NO, and other EF and other reactive oxygen species, etc. Okay, it leads to the loosening of tight junctions between the cells of endothelium. Okay, so it leads to endothelial cells. Okay, so it leads to the leakage of the protein fluid. So it leads to the edema. Okay, and this release inflammatory cytokines leads to the vasodilation, increased permeability, and decreased perfusion leads to the multi-organ failure. And now we will talk about the other mechanism. This release endotoxin activates the factor 8 coagulatory pathway, sorry, factor 12 coagulatory pathway. Also, endothelial cell injury leads to the increased tissue factor and decreased anticoagulants such as the protein C and thrombomodulin, etc. Okay, leads to the activation of coagulation. This leads to the microvascular thrombi, and this leads to the DIC. Okay, disseminated intravascular coagulation. This leads to the what happens in that thrombi forms in the different areas of your body. Okay, and this leads to the tissue ischemia and last also can lead to the adrenal insufficiency. Okay, Waterhouse Friderichsen syndrome. Okay, so and also leads to the multi-organ failure. There is also decrease in the fibrinolysis. Okay, and bleeding and hemorrhage is also seen. It is if you have read the disseminated intravascular coagulation, you can understand this mechanism. Okay. So basic mechanism in DIC is just simple. Okay. So what happens in certain areas of your body? Uh, for example, due to endothelial damage, there is increase in the coagulation factors and platelets. Okay. So in certain areas of your body, coagulation factors and platelets increase. So there will be there will be a formation of thrombi. Okay, but in certain areas of body, what happens is that consumption of platelets and coagulation factor has been occurred due to the increase in other areas of your body. So here the platelets and coagulation factor decreases, so it leads to hemorrhage and bleeding. Okay, so in one part there is a formation of thrombi, and in another part there is a bleeding and hemorrhage. It is uh, a simple explanation of the disseminated intravascular coagulation. Okay, So now let's move on. Uh, there are metabolic abnormality also, okay, such as the insulin resistance, decreased glucocorticoid production. Okay, insulin resistance, decreased glucocorticoid production. Okay, first is can be due to the adrenal insufficiency. Okay, immune suppression we have talked about. Okay, and decreased myocardial contractility, decreased cardiac output, leads to decreased organ dysfunction, leads to multi-organ failure. Okay, so this is about the septic shock. Okay, one more thing, there will also be a lactic acidosis. Okay, lactic lactic acidosis. So now let's talk about the stages of shock. Okay, non-progressive, progressive, and irreversible stage. Okay, non-progressive means compensated and can be reversible. So during the initial phase, uh, um, homeostatic compensatory mechanisms redistribute the blood supply so that vital organs get the enough blood supply. Okay, compensatory changes are mainly due to the widespread vasoconstriction, so it will increase the or maintain the normal blood flow. Okay, fluid conservation by kidney tachycardia. Okay, and in the progressive phase, if the underlying causes are not corrected, so passes to the progressive phase. Okay, characterized by, I have talked earlier about this mechanism also, but let's talk it once more. So characterized by widespread tissue hyperperfusion and hypoxia. Okay, then it leads to the anaerobic glycolysis. It leads to the increased production of lactic acid, leads to the metabolic lactic acidosis, decrease the tissue pH, dilatation of arterioles, leads to the peripheral pulling of blood into the microcirculation, leads to the decreases the cardiac output. Then produces anoxic injury to the endothelial cell, favors development of DIC, widespread tissue hypoxia, and damage to vital organs. This mechanism is the same we have discussed earlier. Okay, now the irreversible phase. When the irreversible phase occur, uh, cellular and tissue injury is so severe that even if the hemodynamic defects are corrected, survival is not possible. Okay, lysosomal enzymes is also released, leads to the which also aggravate the shock state. Okay, myocardial contractile function worsens partly due to the nitric oxide synthesis. If ischemic intestine allows microbes from the intestinal flora to enter the circulation, it may lead to the superimposed bacteremic shock. Okay, the patient develops acute tubular necrosis and results in death. So this is all about the septic shock. Now here you have to remember the point. The for diagnostic purposes, remember that point that septic shock can initially cause cutaneous vasodilation, which produces warm skin. Okay, so remember this point. So now let's talk about the clinical consequences of shock. Hypovolemic and cardiogenic shock usually present with features of hypotension and hypoperfusion. Okay, the features include the altered sensorium, cyanosis, oliguria, weak rapid pulse, tachypnea, cool, clammy extremities. Okay, cool, clammy extremities. And in septic shock, the skin initially may be warm and flushed because of peripheral vasodilation. So these features can be the useful for the diagnosis in clinical cases. Okay, that hypovolemic and cardiogenic shock, there is cool, clammy extremities, while in the septic shock there will be warm and flushed skin due to the peripheral vasodilation. Now, The initial underlying cause that precipitated the shock may be life-threatening because of the, for example, myocardial infarct, severe hemorrhage, or sepsis. Later, multiple organs can be also involved, involving cardiac, cerebral, pulmonary function. Okay, worsen as the shock progresses. The electrolyte disturbances and metabolic acidosis may further exacerbate the situation. Okay. Patients who survive the initial complications may develop renal insufficiency characterized by progressive decrease in urine output and severe fluid and electrolyte imbalances. The prognostic factors are patient with hypovolemic shock can survive with appropriate management, but the septic shock or cardiogenic shock associated with high mortality rate. Okay, so now we will discuss about the morphological features of the organs. So now let's talk about the morphology. Okay, first talk about the adrenal gland. Uh, Lipid depletion in the cortical cell. Okay, it is due to the conversion of relatively inactive vacuolated cell to metabolic activated cells. So the activated cells utilize stored lipids for the synthesis of steroids. Okay, so there is lipid depletion in the cortical cell of adrenal. Focal hemorrhage occurs in the inner cortex of adrenal in severe shock. Remember the inner cortex word in focal hemorrhage. A massive hemorrhage necrosis of the entire adrenal gland is found in the Waterhouse-Friderichsen syndrome, which is associated with severe meningococcal septicemia. Okay, so in adrenal, a lipid depletion in cortical cell, focal hemorrhage in the inner cortex, and massive hemorrhagic necrosis of the entire adrenal gland is found in the Waterhouse-Friderichsen syndrome, which is associated with severe meningococcal septicemia. Okay, now kidney. In kidney, acute tubular necrosis is a major complication of shock. So now, uh, kidney is enlarged, swollen, and congested. The cortex may appear pale. Okay. If you see the microscopy, proximal tubules and focal necrosis of tubular epithelial cells, dilatation of proximal tubules and focal necrosis of tubular epithelial cells. Okay. Tubular ligament may also show pigmented cast formed due to leakage of hemoglobin or myoglobin. And interstitium also show edema and mononuclear cells in the interstitium and within tubules. So this you have to remember. Major thing you have to remember is that acute tubular necrosis is the major complication of renal in the septic shock. Tubules, dilatation of proximal tubules and focal necrosis of tubular epithelial cells. Now lungs are relatively resistant to hypoxic injury. Okay, but when shock is due to bacterial sepsis or trauma, it shows diffuse alveolar damage, which can lead to the acute respiratory distress syndrome, also known as shock lung. The lung is firm and congested, oozing out of frothy fluid. Okay. If you see microscopy, it first develops around peribronchial interstitium, peribronchial interstitial connective tissue, and later in the alveoli. Necrosis. Endothelial and alveolar epithelial cells undergo necrosis and leads to the formation of intravascular microthrombi. Okay, intravascular microthrombi. And hyaline membrane, it is usually seen lining the alveolar surface. It may also line alveolar ducts and terminal bronchioles. These terms and all you have to memorize. Okay. It says in heart, it says petechial hemorrhage in the epicardium and endocardium. It is a coagulative necrosis. Okay, and a prominent contraction bands are seen by a light microscopy. Okay, liver is enlarged cut sections of mottled appearance due to marked pooling of blood in the centrilobular region. Okay, and microscopy. The centrilobular region of the liver shows congestion and necrosis. Brain encephalopathy and cortical necrosis. And gastrointestinal tract shock produces diffuse gastrointestinal hemorrhage, erosions of the gastric mucosa, and superficial ischemic necrosis in the intestine leads to the gastrointestinal bleeding. Shock lung is diffuse alveolar damage, histological features of shock. This thing you have to at least remember. Decutibular necrosis, depletion of lipids in the adrenal cortex, pulmonary congestion, and hepatic necrosis. Okay, hepatic necrosis is seen in the centrilobular region. Now, summarize this morphology. So, in adrenal, lipid depletion in the cortical cells. Kidney acute tubular necrosis in lung is relatively resistant, but in septic shows diffuse alveolar damage with hyaline membrane. Also leads to the acute respiratory distress syndrome, heart coagulative necrosis, and contraction bed necrosis on the microscopy. Liver congestion and necrosis of centrilobular region of the liver. Brain encephalopathy and cortical necrosis and gastrointestinal tract, diffuse gastrointestinal hemorrhage, erosion of the gastric mucosa, and superficial ischemic necrosis in the intestine. Okay, so this morphology you have to mug up, and some of the concepts, if you have understand about the inflammation and basic general pathology, then you can understand this morphology, and it is easier to memorize this all stuff. Okay, so this is all about the, so hope you have enjoyed the video. Thanks for watching. Okay.